Dr. Adesh Patel, who is one of our senior allergy immunology fellows, is getting ready to graduate in 3 months, and he is going to make a presentation to us today. I think this is clearly one of our only fellowship program at the present time, and one that we're really proud of, and so give Dr. Patel a chance to talk about immunodeficiency.
Can you hear me? Okay. Well, thank you, Dr. Bocchini. Luckily today, Dr. Bonnet's not going to give you a 20-minute introduction. I don't have any credentials, so there you go. All right, so today's topic, we're going to talk about humoral immunodeficiency. And pretty much humoral immunodeficiency is when you have impaired antibody or immunoglobulin production. And this could be either to a molecular defect or a failure of interaction between cells. And so there's multiple components of the immune system. You have your B cells, your T cells, NK cells, and other various components of the innate system, such as complements or phagocytes. But luckily for us, the antibodies are produced only by one cell, the B cell. And so that'll be a majority of the focus on this top, because without B cells, you're not going to get antibodies. And when you look at a spectrum of total immunodeficiencies out there, you can see that different lines can be affected, whether it's the B cell, the T cells, a combination of the both, phagocytes, or complements. And as you can see, that majority of these, 65%, are secondary to the B cells. And so when you have humoral immunodeficiency, those are the most common types of primary immunodeficiencies you're going to see. And this is just I just kind of want you to show you that when you make antibodies, that there's a process that the B cell you don't have just all of a sudden you have a B cell formed in the bone marrow ready to go. It takes several steps. You can see that in the bone marrow you have different steps of B cell formation. And so by the time you actually have a mature B cell, it takes at least 3-4 different steps to form, and this is just the mature cell. But then in order to get the full antibodies that normally fight infections from these plasma cells, which are just secreting antibodies, you have additional steps. So I just kind of want you to see that there's multiple steps involved to get the full antibody production. And if you rotated in our AI course, that Dr. Bono probably asked you what are the immunoglobulin levels. And so there's 5 types, IgG, IgA, IgM, IgE, and IgD. They have different functions. IgG is the most abundant type, and it's the only one that actually crosses the placenta. IgA is usually typically found in the GI tract, respiratory tract, your genital tract, and you can also find it in breast milk, saliva, and tears. IgE is typically involved in allergy and parasitic processes. And you have IgD, but typically nobody really checks the IgD level unless you're worried about periodic fever syndromes. But we don't really know as far as the true function of it in the immune system. The other big thing about immunoglobulin levels is they increase as you age, for the most part, especially in early childhood. And so our lab, unfortunately, does not adjust the levels per age. And so you kind of have to look at your Harriet Lane or online and kind of get a table where it shows you the different ages and what the typical range for immunoglobulin levels is. As you can see early on, it's kind of low. You wouldn't expect them to be in the thousands. And so like 600 or 400 might be normal for that age. And so just to make sure that when you look at the labs that you see on EPIC, that you actually adjust for the age rather than just say, oh, it's low. So when you don't make antibodies, you get exposed to certain types of bacteria and viruses. Now you can see from this chart that the CVID is a combined immune deficiency where you have T cells and sometimes B cells affected as well. Then you have the phagocytic defects and complement defects. But with the B cells, when you have antibody deficiency, you're mainly just getting bacteria infections, mainly the strep, the H. influenza, Varicella, Pseudomonas, Staph aureus. Every now and then you'll get enteroviruses, and then you can get Giardia. But you can see there's no Mycobacterium, there's no fungi, which are typically associated more with either combined the T cell defects and phagocytic defects. And so when you look at the infections, you see the type of infections that you typically get, and those usually affect the sinopulmonary tract, GI tract, joints, and CNS. Whereas you can see the other immunodeficiencies typically affect other parts, particularly the skin, such as the phagocytes and the T cells. So when you have other defects, such as SCID, whereas T cell effects, you'll see those presentations. You can see this baby on the red with Oman syndrome with a really bad eryderma. Sometimes when it's a Wiskott Aldrich, you see the bad eczema. If they have CGD, you'll see these abscesses. If they got LAD or leukocyte adhesion, which is a phagocyte defect, you'll see the problems with the umbilical cord. But with antibody deficiencies, you typically don't find a lot of physical findings, and that's key. You have to remember that. So you're not going to get easy tell just by looking at the baby when you see some type of noticeable defect. And so there's very typically limited findings, except for XLA, which we'll talk about in a little bit. But the main diagnosis is trying to get a really good history, and mainly their history of infections. And so this is from the Jeffrey Modell. And you can get this just on Google Jeffrey Modell or top 10 warning signs, and you can print this off, put it in your practice or in your clinics, just to kind of remind you that certain signs are more concerning about finding a immunodeficiency. And you can see that when they have 4 or more new ear infections within a year, 2 or more serious sinus infections, 2 or more months of antibiotics with little effect, 2 or more pneumonias, if they fail to grow, if they have recurrent or skin abscesses, if they have persistent thrush, which like I mentioned earlier, you see that more in T cell defects rather than the antibody defects. And if they need IV antibiotics to clear infections, or if they have septicemia, recurrent hospitalizations. Another thing is when you ask about family history, make sure they don't have a family history of primary immunodeficiency. And typically, if they do have family history, if it's significant enough, you'll notice that a lot of their family members died at an early age. So these are the antibody deficiencies that we'll talk about. We have aglobulinemia, common variable immunodeficiency, hyper-IgM, selective IgA deficiency, and transient hypogam of infancy. So going back to this diagram about how the B cell forms, as I mentioned earlier, there's different types of genes that are needed to kind of progress to the next step. And so with XLA, it's X-linked, and it affects 1 in 190,000 male births. And 40% of these are born into a family with a previously affected family member, and typically is first noted between 3 and 18 months of age. And so you would consider this when you have a male patient, as you can see, it's X-linked, and you see pretty much a marked reduction in all classes and subclasses of serum immunoglobulin levels, and typically it's below less than 100. You can get the IgG sometimes a little bit higher, around 200 to 300. But the big finding is that when you do flow cytometry, you'll see that less than 2% of the B cells are not there. And in addition to these caveats, you'll also need either that the male family member is documented to have either agglomeratin and 2% B cells, another male family member from the maternal lineage, or you would look for this gene defect known as BTK or Bruton tyrosine kinase. As I mentioned earlier, there's one physical finding that you would see in XLA is no or very little tonsils and lymph nodes. And so when you see early on, when you're doing your physical examinations on your babies, just make sure they do have lymph nodes and tonsils, because if you don't, you should be concerned. And you can consult AI or get immunoglobulin levels, especially if you know they've had recurrent infections. The other thing, sometimes you'll see a little bit older children, and just remember that sometimes these older children already had tonsillectomies and adenectomies, so just be aware of that. And so as I mentioned earlier, the main problem with XLA is that you have a defect in the BTK gene. And so we're still before this mature B cell, before you can make any of the antibodies. And so this defect comes way before in the bone marrow, before the mature B cell. And so you're blocking off everything else. And so, as you would expect, you get no immunoglobulin levels of any type. And so, as I mentioned earlier, with XLA, you kind of get some of the sinopulmonary type infections, the streptococcus, H. influenza, and then sometimes you can get the gram-negative species causing sepsis, osteomyelitis, septic arthritis. And then the viruses I mentioned, the enteroviruses, if it's severe, before they came out with IVIG, and we're really not really picking up on these, some of these babies were dying of meningitis and encephalitis secondary to echovirus and Coxsackie viruses. But now with IVIG, you really don't see that as much. And then the other thing would be if they have mycoplasma from arthritis or diarrhea from giardia. And then when you look at flow, if you look at the actual flow, you'll see it's pretty obvious that they're not going to produce any B cells, mature B cells. The other form you can get is, remember, the XLA is an X-linked, so you would see that in boys, typically. However, you can also have females that can have this, and if it's a female, you're more likely to get autosomal recessive. And there's kind of the same thing. It still comes way before this mature B cells. And so you block off all that, you get the same type of phenotype, no immunoglobulin levels. And these are some of the genes kind of just like with the XLA, you got the BTK. But with autosomal recessive, there's other genes associated with the B cell receptor. So moving on to CVID. This is actually the most prevalent form of severe antibody deficiency, and it affects both children and adults. And the variable stands for because there's a heterogeneous clinical manifestations that's typically associated with CVID, which I'll show you in the next slide. And a lot of these patients, unfortunately, go underdiagnosed, but it's estimated to be actually 1 in 25,000 individuals. And typically, they don't get diagnosed until early adulthood, and so there's actually a delay in diagnosis. One, because they don't typically sometimes can have milder phenotypes and just kind of go undiagnosed. And so with CVID, as you can see, we're past the mature B cells. And so when you're going to look on the flow, you're going to see normal B cells, but you can see that the problem is when they forming plasma cells, which are the main producers of the antibodies, or the memory B cells, which are long-lived. And so you see marked reductions of IgG or IgA and IgM. There's usually 2 standard deviations below. Typically, you want diagnosis until age 2 or older, and you don't have other defined immunodeficiency states. And as I mentioned earlier, the defect typically happens after the maturation of the B cell. And so when you have absence of B cells like you had with the autosomal or the X-linked, this pretty much gets excluded. And so when you see no B cells, it's not going to be CVID. And I guess this is more for immunologists, but there's certain phenotypes when you have low switched memory B cells, they're usually to have more of a severe prognosis. And so unlike XLA or AR, autosomal recessive aglobulinemia, which are usually secondary from identified gene defects. Unfortunately for CVID, 90% have sporadic mutations that have not been identified for the specific gene. And about 10% only have a gene defect, which will go on the next slide. But at least 10% have either a family member with CVID or selective IgA. And so, as I mentioned earlier, the main problem is the process of B cell maturation, differentiating memory B cells. And so, as I mentioned, majority of these patients, over 80–90%, they have no family history or no known gene defect. And so the most common variable is a mutation in this TACI. And this TACI receptor is really on the B cells, but it interacts with the T cells, which is needed to make antibodies. And then, so looking at the whole B cell structure, you have the B cell receptor, which, as I mentioned earlier, that when you have defects in here, you get the autosomal recessive type agglutininemia. But then you also have this B19 or CD19 complex that gets used to get activated. And so you can have mutations in any of those parts. You can see 19, 21, 81. And so when you have defects in that, that can kind of lead to CVID-like phenotype. And most of the patients typically have no disease or the complications from it. You can see 62–78%, whereas only 22–38% actually have some of the other variable phenotypes. And you can see they can have cytopenias, lymphoproliferation, or enteropathy. And the other big key between the XLA or the autosomal recessive agglutininemia is that these patients can get a granulomatous disease. But they in addition to that, you can see that they get the infections, autoimmune, pulmonary, gastrointestinal, liver disease, malignancy as well. And so kind of the same thing. You know, when you get infections, you're kind of getting the similar type of same sinopulmonary type infections. The mycoplasma, urema plasma causing urinary tract infections or joint infections. And so when they looked at a cohort of around 400, 500 patients, the most common autoimmune findings was thrombocytopenia. And so typically you see ITP or autoimmune hemolytic anemia. That cannot be the presenting disorder in these patients. And up to 25–30% of these patients can have this. And there's a whole wide variety of autoimmune diseases. I mean, pretty much like the hypothyroidism, rheumatoid arthritis, vitiligo, autoimmune hepatitis, juvenile rheumatoid arthritis, a whole class of autoimmunity that you can see with CVID. And this is kind of a summary chart saying you can see that CVID typically you have one on the side, the infections, as I mentioned, the sinopulmonary, the GI, the joint infections, and then you have the autoimmune part of it as well. The other organ that CVID affects is the lungs, and about a third of these patients with CVID typically have some type of lung disease, and this can present in two different forms, either the obstructive type where we see asthma or bronchiectasis, and then you can also see the restrictive disease, lymphocytic or granulomatous infiltrates. And so when you look at the CT, you'll see different type of phenotypes. You can see the bronchiectasis right here. Again, then you can see ground glass opacities around there. And then there's apparently two types of pulmonary nodules. You can see the small over here, and then you can see the massive pulmonary nodules. And when you see kind of like this pulmonary nodules, it can kind of resemble this disorder known as granulomatous lymphocytic interstitial lung disease. And you see the fine, coarse, reticular type of pattern with fibrosis and nodules mixed together. And the studies have shown that the herpes 8 virus has been implicated in the pathogenesis of this. The other thing as mentioned was that it can also affect the gastrointestinal disease tract, and so you can get IBD type disease. The other thing would be this kind of nodular lymphoid hyperplasia, You can see the very close up right there. Bacterial overgrowth, pernicious anemia, malabsorption. And as I mentioned, compared to the other aglobulinemia, you get more of the granulomatous disease, and the most common site is the lung, as I mentioned earlier. But you can get other organs involved. And these patients also can be affected by malignancy. The most common form is non-Hodgkin's lymphoma, but they can also get kind of your solid organ tumors with breast cancer, gastric cancer as well. And so when you look at the Kaplan-Meier survival curves for these, you can see that when they have no other, when they just have infections and no other autoimmunity or anything else, you can see how good the survival rate is, because we'll just give them IVIG and they'll do well. But when they start having these complications, you can see that the survival significantly drops. And so it's really important that when you suspect infections and autoimmunity, that you kind of pick up check immunoglobulin levels and make sure they don't have CVID, because if you kind of let them progress, they ultimately do poor. So the big differences between the XLA and the CVID is that with XLA, you typically see that at 6 to 12 months. And the CVID is any age, but typically you see it in the first and third decades. XLA, as I mentioned, is mainly in males. The autosomal form can be male and females, and CVID is both male and females. As I mentioned, the CVID, typically you see more of the autoimmune manifestations and the lymphoma and the granuloma disease as well. The big physical finding in XLA would be that there's hypoplasia or absent lymphoid tissue, mainly the tonsils. And then compared to XLA, CVID, you have a decreased IgG. You don't necessarily have to have both IgA and IgM low, whereas with the XLA, just because of the underlying pathomechanism, that you would get all the cell lines kind of low. And as I mentioned, the other big difference is that because of where these defects are, you're not going to get any peripheral mature B cells, whereas CVID, you'll normally have some. And the molecular analysis, so when you get a patient that has low B cells and completely low immunoglobulin levels, especially in a male, then the BTK mutations, that's where you want to look for, whereas CVID has been associated with other ones, but it's not the primary underlying molecular defect. So we talked about the autosomal form, the XLA, and the CVID. So last, we'll talk about hyper-IgM. And this, you can see that you have this mature B cell, and then in order for it to, at baseline, it only forms IgM. And so in order to get the IgA, the IgG, the IgE, you need these two, and well, about 3-4 of them. You actually need these genes, proteins, to kind of make the conversion. Without the conversion, you're just building up IgM. And so that's what it essentially is. You pretty much have normal or increased levels of IgM, but then you have the deficiency of the IgG, IgA, or IgE. And there's two different main forms. The one other, as I mentioned earlier, you have the AID and the UNG, and then the CD40. The CD40 X-link is the most common, which you can get both B cells and T cells. With the diagram, as I showed you earlier, the B cells need the T cell help to make the antibodies, and so the CD40 is on the T cells, and so when you have a defect, you get a combination of T cell and B cell effects, whereas the AID, it's mainly in the B cell, these proteins, and so it only affects the B cells. And so there's 5 different types, as I just kind of went through, mainly the CD40 gene defect and the AID and the UNG. Now, selective IgA is the most common immunological defect in humans. It has a high prevalence of between 1 to 100 to 1 to 1,000. And there are certain risk factors, such as having a family history of selective IgA deficiency or CVID. And pretty much the definition is when you have a deficiency of serum IgA in the setting of normal levels of all the other immunoglobulin levels. And typically you can't diagnose this until age 4. Some of the reports now say that it can take up to age 6, 8 to kind of fully develop the IgA. But typically, you just kind of follow them before you even consider this. And then you also want to make sure there's no other causes of hypogammaglobulinemia that have been excluded. And so the big key with selective IgA is that some of these patients can progress to the CVID, the more severe form. And so you just kind of monitor them for that, just because CVID can lead to more detrimental manifestations. And it's also been associated with IgG2 subclass deficiency. And so the reason most of these patients don't really walk around undiagnosed is because they're asymptomatic. And only a third of them actually present with any type of manifestations. And if they do, they get the same recurrent sinopulmonary type infections. They can also have autoimmune disorders, such as lupus, Graves, RA, and again, with the Giardia causing diarrhea. And the other big thing is that when they have anaphylaxis after getting transfusions, sometimes they can have anti-IgE antibodies that subsequently causes them to have the anaphylaxis. Now, this manifestation called transient hypogammaglobulinemia in infancy, you have pretty much IgG levels that are a little below the 2 standard deviations when you actually compare them for age. And then the other immunoglobulins are usually diminished, but really could be normal as well. And this typically occurs when you have no other immunodeficiency conditions involved. And it usually persists beyond 6 months of age. And so you kind of have recurrent respiratory infections, otitis media, bronchitis. You can sometimes have life-threatening infections such as bacteremia or meningitis. And so early on, when you're at birth, all the immunoglobulin levels that you have for IgG is going to be from your mother. And so between this window, between usually 4 to 6 months, the baby doesn't, starts forming it, but you see that it's way below the actual normal levels of IgG. And so some levels that you'll have is mainly IgM. And so there's a window period where, it takes time for the baby to start making his own immunoglobulin levels. And sometimes with this transient hypoglam, for unknown reasons that really haven't had explanations exactly why some people kind of have physiological lags from making these, but pretty much is their immune system is kind of running at a slower pace, and so you're not getting the IgG level at around that 4 age. Maybe it might be around that 8 or 9, 10 months later on. But the good news is that they have a good prognosis. Usually spontaneously recovers by 9 to 15 months. And you'll typically see the IgG become normal between 2 to 4 years of age. And so when you look at the labs, the first thing you want to get is CBC to look for lymphopenia or look at the white count levels. You want to check your immunoglobulin levels. You can check their antibody response to tetanus and diphtheria, pneumococcal antibodies, and then the flow. And as far as vaccination in these children, the guidelines suggest that when they have XLA or CVID, the more the severe antibody deficiencies, you want to avoid the live vaccines, your oral polio, smallpox, live intranasal, yellow fever. If it's less severe, mainly just avoid the oral polio, BCG, and yellow fever. You can give the other vaccines. They don't seem to have complications when you do that, when they only have like the selective IgA or IgG subclasses. And so the treatment would be IVIG and antibiotic prophylaxis. And IVIG has been shown to have significantly reduced infections and early mortality. And so early diagnosis is key. Now you can wake up.
Thank
I'm sorry, go ahead.
It said on your second to last slide that there's no data for varicella or rotavirus. So what do y'all
Well, if it's severe enough, if it's XLA or CVID, then yeah. I mean, because with CVID, there's also some of them have T cell defects as well. And especially with the live vaccines, you need the T cell function to be there. So yeah, if it's severe, I would not give it, especially XLA and CVID. And you kind of have to look at each individualized each patient, because say they could be asymptomatic selective IgA, completely normal, not having anything. And so if they're doing fine, you just kind of, you can kind of individualize and say, hey, this patient might be able to tolerate it. But usually with selective IgA, the lower things like this, you're not going to diagnose until like age 4, 5, 6, because the time period to get IgA to get to adult level, it takes several years. And so by that time, the baby's already going to get it. Like, I mean, unless this is like SCID or really bad, most likely that baby would have gotten it anyways.
So I have a question.
You did mention relationship of IgG2 subclass deficiency. When are IgG subclasses important? That's sort of been something that's kind of gone up and down over the years.
Yeah.
When would you look at IgG subclasses?
So that's actually a very controversial topic. And so when I was at my board review DVD, one of the well-known immunologists at NIH said he doesn't check them. And then you have other immunologists that checks them. And so it's very controversial as far as is there such a thing as subclass deficiency and is there significance behind it? Now, we do have, I think maybe 1 or 2 subclass deficiency patients. And usually those, it's all, again, individualized and depending on their symptoms. If, say, and usually with subclasses, you get more of the sinopulmonary infections. You're not getting herpes or candidemia and stuff like that. You're getting more of those sinopulmonary type infections. But say they, they had multiple pneumonias or multiple sinus infections that had required multiple antibiotics. And if the IgG is kind of borderline-ish low, then yeah, you can get the subclasses, and then you can give them a trial of the IVIG, see if that helps them. But as far as just routine, no. It's pretty much we know you have borderline IgG levels, or if they have kind of like that history of the sinopulmonary recurrent pulmonary infections, and yet all the immunoglobulin levels are low, then you can maybe consider getting the subclasses. I don't know if Dr. Bonner has additional.
As you mentioned, the immunologists, there are 2 groups. That if you have specific antibodies present, they don't check IgG subclass. But I'm of the other group, that if the patient is sick, you check the IgG subclass. So you have IgG2 particular low, that person has a problem. So I don't treat a piece of paper. That immunodeficiency is, I assume that he's the head of the allergy and infectious disease that they conflation. Yeah. I differ with him. That's all right. But we treat, I'm not just alone, we have 2 groups of patients. The patient is sick. I can't say that I'm not going to check subclass. Don't be blind. Check. And treat the patient. They are going to get the immunoglobulins and they will be better. So this is important to deal with a patient. Particularly, as you mentioned, with IgA, there is IgA deficiency, and the vast majority of IgA deficiency, they are fine. They don't have a problem, but we follow in case they have a common variable later on. But if the person has a problem, find IgG to subclass, there's definitely infections there, and they deserve to treat.
So with the drops in the pneumococcal disease that we see, there's some evidence that now any residual pneumococcal disease that we see is more likely to be related to immune deficiency. And some of the data suggests maybe 10 to 15% of kids who have invasive pneumococcal disease now in the Prevnar era actually have an underlying immune deficiency. So the major question is, when should we do some testing for immune deficiency in a child who's recovering from pneumococcal sepsis or pneumonia? Should it be at the time, or wait a few months, or wait a year? When do you do that?
Probably wait it's a few weeks to a month, mainly because when you look at the levels at acute infection, it's going to be skewed, because the antibodies are being utilized to fight the infection. You might not get it. And the other thing, as you mentioned, if they have, if you're worried about recurrent pneumococcal infections, the other thing I didn't mention on here is this humoral immunodeficiency. But in addition to humoral immunodeficiency, the other thing you want to worry about is complement deficiency. And some of those, especially the early complement factors, the 1, 2, 3, those have been associated with the pyogenic strep infections. But yeah, several weeks to a month in between afterwards. Once they, kind of healed and kind of gotten over, then you can kind of check it. Because if it's low, it's going to be low. It's not going to be, low just during that time.
So then
Yes, that was a great overview. I noticed one of your slides you have ITP presenting as so normally we don't think of immunoglobulin deficiencies in ITPs or immunothrombocytopenia.
Yeah.
We see it in the mother and baby. The question is, when would you investigate with immunoglobulin? Because we would look at the history for us, and at least in the perinatal period, like ITPs, like Rh disease, the antibodies in the cells. So you'll have a history, whereas in the immunothrombocytopenia, there is symptomatic. If you give a normal platelet, it will be destroyed. So that's a very simple, cheap way to make the diagnosis. So you give IgG, both to the mother and the baby, in subsequent pregnancy. So again, coming back to the question, because I've not read anything in the literature about investigating these kids in terms of immune disease. Can you comment on that? So
from the slide did say that they can present with that type of autoimmune manifestations, but typically when they looked at cohort studies over, there's a couple one that looked at 476 patients, another one at 2,200 patients. Over 90% of them had pneumonia or some type of infection. And so when you have a combination of that too, that's when you would get concerned about it. But if you're just plain ITP by itself, that's why you probably in your literature is not going to say, hey, because then you're rarely ever going to see something like just by ITP, but it usually presents with some type of infection, primarily the pneumonia or some type of sinus infection in combination of those two.
Okay, so
Since we have a lot of time, you did a great presentation. You mentioned that in physical findings, when you see tonsil lymph nodes, you are comfortable, and their absence, you're worried about that. Also, if they are enlarged more than usual, you're worried. So either absent, you're worried of the congenital A-gamma or hypogammaglobulinemia. If it is enlarged, venous enlarged of the liver, you worry about lymphoproliferative disease as one. There is a test that's done on every child enter this hospital in any floor. Can you benefit from that cheap test?
CBC?
Exactly. Every patient in the hospital has CBC at least once. How can this help you to say, I'm worried about this patient? What's in it?
Well, this is
in pediatrics.
in pediatrics. The two big things you will look at. Well, I guess maybe three, but the two big things you will look at is the white blood count and then the differential for that, the neutrophil counts, because then you can see you can diagnose LAD, leukocyte addition effects from that, because they usually have leukocytosis or cyclical neutropenia. On the other hand, another thing you'll look at is their lymphocyte count. The lymphocyte count is actually 2/3 is made by T cells, and then the other 1/3 is B cells. So when you see that lymphopenia, that should kind of suggest to you that there might be a T cell defect, and that's actually when they looked at patients that had severe combined immune deficiency. One of the diagnostic features early on was lymphopenia seen on the CBC. So just having that CBC can show you that it can kind of, you do a little screening for any type of T cell defects. And then lastly, you can look at the platelets. There's low platelets, typically associated with Scott-Aldrich. That's one of the other big key primary immune deficiencies.
So a simple test as done in every patient can give us a lot of information here. Any type of cytopenia you will worry about it, particularly lymphopenia. What level of lymphocytes would make you worry? And I'm shocked.
1,500 less, around 15,000, 1,500.
But even 2,000 in a child under 2 years of age, although we consider 2,000, that's wonderful in an older child, and a young child, it's not a good thing. So, but I mention these things because many immune deficient patients, either they die before diagnosis or they are diagnosed after years of having the problems. It is better to suspect early and investigate, and we don't have to do a $1 million workup, but can easily detect early and save lives and save admission to hospitals and a lot of antibiotics. You mentioned the treatment of the humoral immune deficiency is immunoglobulins. Is there one type or more than one? And if there is more than one, what difference is there?
One type of immunoglobulin? Yeah, there's like several immunoglobulin levels, and you can give it in several forms. IVIG, you can also give it sub-Q where they can take it at home. And each of them have different types of, most of the time, all of them have IgG in there. There's very minute quantities of IgA. So when you replace, when you give somebody supplemental IVIG, all you're doing is replacing IgG. And so that's the only level that you will follow. You're not going to increase any levels of IgA, IgM, or IgE. And so,
why is that? And these came from normal people from plasma, and all the immunoglobulins are there?
yes, they are.
Then why are you saying just IgG?
Well, because IgG has a half-life of 21 days, around 21 days. The rest of the half-life of IgM is 5, IgA 6, IgE about 2.5, 2. So by that time, when it's already pooled and stored, you already have, you already lose it because the half-lives are so short, whereas the half-life of IgG is around 21, 28 days. And so that's why you only get IgG in there, in the solutions.
So with the different types, is it just a price or some components that you have to select for certain patients?
There are certain components. Mainly, the two big things that you kind of worry about is, like as I mentioned, there's minute quantity of IgA in there, and so there's patients that have that anti-IgA antibodies, especially when they don't make any antibodies, or limited amount, more of kind of like the CVID, where you have just small amounts, so they can actually have antibodies against IgA. And so when you give preparations that have high levels of IgA in them, they can theoretically be at risk for having anaphylactic reactions when you give them. And so you would pick preparations that have more of the lower quantities of the IgA. And the other thing, if they already have underlying kidney problems or renal problems, there's only one preparation that has sucrose in it, so you would not get that to them. That can make that renal function worse.